So we thought of doing these unknown slides cases at the end of the day. They are challenging cases, and the intention was at the end of the day we should not end the day with a didactic, boring presentation rather than something more interactive so that you will have the enthusiasm to come back next morning, and you will go home with nice memories of how the grand finale of the first day was. So I'm going to show some cases. They're good cases, and I'm sure that along with the entertainment value, they will also provide a lot of information. Just a day before I came here, I was in Canada giving a talk, and someone from the podium asked a question from the audience, and I'm going to ask you the same question. How many pathologists does it take to make a malignant diagnosis? 2? 1? The answer is 10, because one less would be benign. B9. So I thought I'll ask you some questions. So why was the computer so tired when it got home? Running is one, but the answer is because it had a hard drive. So this is the first case. It's a 23-year-old Hispanic woman who presented with epigastric abdominal pain that started during her second month of gestation and steadily worsened. The imaging showed a 12 centimeter, so just imagine the size, 12 centimeter mass coming off the inferior aspect of her stomach. So attached to the greater curvature was seen coming off the greater curvature. I'll show you the images and then we'll have a nice discussion. So you can look at the architecture, cohesiveness, single cells, mesenchymal, epithelial, something else, cellularity, vascularity. They're quite pleomorphic looking. There's definitely some spindle cell proliferation, and that's higher magnification, showing some mixture of cells, some vascular. There is definitely some cells suggesting adipose differentiation. There are epithelial histiocytes as well. And there are some thick bundles of collagenized stroma or something else, maybe desmoid looking. Clearly, she had an exploratory laparotomy 2 years prior to this FNA, so maybe it's a desmoid tumor. You are seeing these thick bundles of collagenized. There were histiocytes containing something in the cytoplasm, maybe some organism, maybe PAS positive material. We did not have enough to immunostain, and shown here as well. And again, maybe histiocyte, maybe a degenerated adipocyte, maybe an epithelioid cell, maybe a clear cell from somewhere. So we'll have a discussion. Adequate, abnormal, neoplastic, malignant. A yes or no? Yes. What type? You can just tell me carcinoma, sarcoma, melanoma. Carcinoma? Okay. So this is the differential, maybe reactive inflammatory, maybe infectious, maybe neoplastic, maybe soft tissue, maybe lipomatous tumor, maybe fibrohistiocytic tumor. So being a good colleague of yours, I will give you more history. So this is a 23-year-old female who's G3P3. He has her first child, which was spontaneous delivery. Second was also SVD, 4 years after the first child. But this second pregnancy was complicated by appendicitis, for which she had an emergency exploratory laparotomy and then appendectomy. The most recent pregnancy, which is this one, 3 years later, was significant for persistent epigastric and lower abdominal pain. which is more pronounced on the left side than on the right. The second trimester sonogram and MRI showed a left upper quadrant mass, and subsequently she underwent a C-section. The clinical differential diagnosis presenting to us was degenerating uterine fibroids, huge fibroids, versus a gastrointestinal stromal tumor. As a matter of fact, GIST was the diagnosis which was strongly favored by the clinical team, and we were told regardless of what we will diagnose, they will take the patient to surgery, rather a debulking surgery to take out the GIST, 12 centimeter GIST. So any last minute diagnosis, differential diagnosis? So our approach was very different because we were able to look at those histiocytes under polarized microscopy, and we thought that there is some polarizable material. So this was my case. I signed it out as benign with polarizable suture type material. And the surgeon laughed at us and said, 12 centimeter mass attached to the stomach, and you were calling it suture-like material. So in any case, a debulking surgery was done, and a big tumor was taken out, or whatever it was, measuring 29 centimeter in greatest dimension and weighing a kilogram. And it was adhered to the greater curvature of the stomach. So here's the tumor which was sent to us. It is nicely encapsulated, and 29 centimeter tumor, mass almost weighing a kilogram. Gauze material, which you see here, and that was the histology, and that's the polarization, and those are the multinucleated histiocytes, and that's higher magnification, which shows the polarizable material, which we also saw in one of our slides, but that's gauze. So the final Hopkins diagnosis in this case was gossipyboma. So gossipyboma is a term which is given to the surgical sponge which is accidentally left inside a patient's body. It's a combination of two words, the Latin gossypium, which is for cotton, and boma, which is a Swahili word for place of concealment that you hide the cotton gauze, also known as textiloma, gauzoma, muslinoma. So these are all the other names. I'm sure that you know Ammon Shea, who has his own version of Oxford Dictionary, and he said that a memento is once asked a surgeon what is a gossipyboma, and surgeon was so arrogant that he said a memento that we surgeons sometimes accidentally leave behind to commemorate our presence in some poor patient's abdomen. So that's a gossipyboma. Its incidence is not trivial. 1 in 100 to 1 in 5,000 surgeries, you have gossipyboma. It's frequently misdiagnosed as cancer, especially on imaging. And the most commonly encountered gossipyboma is the rectangular cotton laparotomy sponge. It's more common in abdominal procedures. Our patient had an exploratory laparotomy and emergency appendectomy. It's more common in GI. Our patient had an appendectomy. It's more common in female. Our patient is a female, so everything fits. It's more common in obese patient. Our patient weighed 300 pounds. It's more common in emergency cases because everyone is running around to control bleeding. Our patient had an emergency room appendectomy. More common in hemorrhagic procedure for the obvious reason you're trying to control bleeding. Our patient was bleeding. It's detected within the first year in 40% of the cases, but in nearly half of the patient, the diagnosis is made 5 years or later. And overall mortality is estimated at 11 to 35, but it has significant morbidity, chronic pain, infections, and all those things seen in 50% of the patient. There are other reasons for having a gossipyboma, as you can see here. That's also a gossipyboma. Sponges are most common, 2/3 of the time, 1/3 of the time these are instruments. And the cost is amazing, the liability cost. Each incident is at least $200,000, which are paid to the patient in the US. And sometimes it gets significantly higher if the patient will die of the disease. I like the title of this article, Forget Me Not, Gossipyboma and Pregnancy. And as you can see that they are nicely encapsulated, and this one was intact cotton gauze, which was seen in this patient. So as you can see here, that we have seen other example of Gossipyboma, again retained sponges with the cotton fibers, which are seen in the cytoplasm of these multinucleated cells. These are more examples. So take-home message is that clinical history may hold subtle clues. Radiological interpretation can be totally misleading. In this case, it was thought to be a gastric tumor or a cyst. Cytomorphologic features are rather underwhelming. All we saw were few macrophages with suture-type material, and the actual lesion was a 1 kilogram pseudotumor, which is almost 29 centimeters. So Gossipyboma is an important pseudotumor, and just like pancreas, soft tissue FNAs are treacherous. So maybe next time we have an ISU tutorial, we'll have a lecture on soft tissue tumors, but they are very difficult. So I'll end up the first case with a beautiful cartoon. This surgeon is telling the patient, post-op, the good news, I found my cell phone. The bad news, I left it on vibrate. So another Gossipyboma. So here comes a question, Shahid. Why didn't the skeleton go to the dance? He has? Oh, you have read this somewhere. Exactly. Very good. I'm impressed. So the second case is a 58-year-old man with bilateral lung transplants 3 years ago for severe COPD. This is a easy case, and I'm sure most of you will guess right away the moment I show you the images. Everyone is laughing. I have such a bad reputation. The patient presented with pleural effusion and a pleural base lung nodule. Whole body pan CT scan, including brain, showed no masses or other lesion. So yeah, carefully read the history because it has importance. FNA of the lung mass was done and was worked up with a battery of immunostains. A pleural effusion a day earlier than this FNA was signed out by a colleague of mine as metastatic lung adenocarcinoma. Could be helpful, could not be helpful, leading or misleading, it's up to you. So that's the FNA of the lung mass, pleural based. So clearly epithelioid looking, high NC ratio cells, macronucleoli, quite pleomorphic, mostly cohesive, some single cell as well, mitotic figures, maybe some stroma or something is seen there. Lymphoid, maybe, there is a little bit of basophilic cytoplasm, but to me they look more epithelioid and have a little bit more cytoplasm than what you expect to see in a typical lymphoid lesion, unless it's a special type of lymphoma. More or enough? Okay, but you have to tell me the diagnosis now. So again, quite pleomorphic, some binucleation, little bit of cytoplasm here, very basophilic cytoplasm, some cytoplasmic tails, macronucleoli, and some of these nuclei, but overall, a discohesive pattern or loosely cohesive pattern is seen here. Now you can see even some suggestion of gland formation, high NC ratio, cytoplasmic tail, but too much cytoplasm even for an anaplastic large cell lymphoma, which certainly can happen in post-transplant lung. More? Mitotic figures, plasmacytoid appearance, another mitoid. So if you see it in a lung on a typical day, what would you call it? Non-small cell carcinoma, favor adenocarcinoma. But it's a pleural-based mass. Maybe I'm trying to trick you here. It's a mesothelioma, which absolutely is a very valid differential diagnosis in this case. So I think the differential diagnosis, based on what I'm showing you, the mitotic figure, epithelial looking or epithelioid looking cells, would be anaplastic carcinoma, pleomorphic sarcoma, anaplastic large cell lymphoma, anaplastic tumor, could be epithelioid mesothelioma. So what do you think? I didn't even ask you that adequate exercise. So we all know it's adequate. Do you think it's abnormal? I'm sure you will say yes. Do you think it's neoplasm? Absolutely neoplasm. Benign or malignant? All of you will call it malignant. But what type? You can ask me 50 immunostains and I'll give you answer. Anyone. Let's have that fun. Vimentin is not a good stain. I don't even consider an immunostain. Anything else? WT1 negative. Napsin A negative. Cytokeratin negative. BAP1 was not done but would have been retained. CD20, for which lesion? Dendritic reticulum. That would have been negative. Yeah, we have just done 6 immunostains. You can do 50. You just ask and I'll give you the answer. LCA negative. CD30 negative. EMA negative. Milan A negative. Which one? Negative. HHV8 negative patient is not HIV. Anyone? What is it for? Oh, EBV, negative. It's an excellent thought because patients post-transplant. It's from the same patient, right? Any other? We are very careful. Any other stain? CD38, CD138, negative. Which one? Nut is negative. You have to ask me the stain and I'll give you the answer. So CD117 would have been positive. CD117. But I'm not giving you more than that. You have to ask. CD? CD5 negative. MPO would have been negative. Dog1 would be negative. Which one? SOX4. Cell4 negative. It's excellent idea. When nothing fits, think of germ cell tumor, Cell4 negative. There are so many immunostains. But sometimes we don't remember, so do a Yahoo or Google search and bring up the whole list and read the immunos. ERPR negative. Which one? No, negative. Which one? Tryptase negative. PCR wasn't done. Or for PSA, NKX negative. Any history? I already gave you the history. The patient had COPD for which he got lung transplant and had these nodules, and the nodules were FNA'd. CMV? I don't know if we have immunostain against CMV, but would have been negative. Come on, Nassan, think of some immunostain. When you give up, then I will tell you what was positive. But you have to acknowledge we give up, we lose. Huh? HCG, again, good thought of germ cell tumor would have been negative. So you did all the epithelial markers, you did most of the mesenchymal markers, you did all the melanoma marker. What is the other differentiation? You did the mesothelial marker, calretinin negative, CK56 negative, D240 negative. Which one? CD34 negative. CD68 negative. Negative. You can say all the numbers, all negative. CD20 negative. CD1? 1A for, okay, negative. There were no multinucleated cells, no eosinophils, nothing. Which one? Myogenin would have been negative. GFAP? And what would you do if GFAP was positive? Because there's nothing left on the list, right? So you want to know? GFAP was positive. See? This was the last thing on your immunolab menu. You used all the stains. So what are GFAP positive tumors? They are glial and neural tumors. They are pleomorphic adenoma, cartilaginous tumor, chordoma, soft tissue myoepithelioma. It's not myoepithelioma. You asked me about the stains on smooth muscle, right? You asked me S100, it's not a chordoma. It's not a cartilaginous tumor, S100 again negative. Pleomorphic adenoma, but did not have features of pleomorphic adenoma. So we are left with glial and neural tumor. So if GFAP is positive, do you think it could be a glial tumor? So this was a case I actually used. I moderated a session at ASC, and you would remember us if we do this diagnostic slide seminar where we bring 4 expert panelists, and everyone in the audience of 600 plus people have the audience response system. We show the slides and everyone votes on the diagnosis. So I had 3 past presidents of the ASC, American Society of Cytopathology, the most experienced people who evaluated this. The first panelist, past president of the ASC, most senior person, called malignant favor poorly differentiated carcinoma. The second panelist said post-transplant lymphoproliferative disorder. And I gave them in the history the tumors lesion stained with GFAP. And the third one said some kind of GFAP positive adenocarcinoma. Then the audience also voted. 25% said glioma, NOS, or GBM. 22% called it adenocarcinoma. 11% still called it lymphoma or PTLD, even with GFAP positivity. And 42% have miscellaneous diagnosis, transplant rejection, atypical carcinoid, carcinoma, X, pleomorphic adenoma, mesothelioma, MPNST, and I do not have any diagnosis. So what do you think is going on? History is the key. That's you holding your face. So is there any suspense for history? Where is the rest of the story? So when you say we all give up, I'll give you the history. Mudassir, you have to say you gave up, then I'll give you the history. You give up? Yes. Okay. Here is the history. Patient had bilateral lung transplant for severe IPF. Explanted organs were from a donor with a history of GBM. You should be more specific in asking me. I can tell you the answer right away. So the lung FNA actually is metastatic donor-acquired GBM. It was positive as GFAP, CD56 negative for these stains. And donor-acquired solid organ tumors are a very rare complication for organ transplant, and it illustrates the potential problem. There are more patients on the list than the organs which could be transplanted, and hence it's perfectly legitimate to transplant organ from patients who have skin tumors or primary central nervous system tumors, which the donor had in this case, but the lungs already had occult metastasis when the lungs were transplanted. So it's a donor-acquired GBM, which is pretty rare. But unfortunately, it can happen. So as shown here, it has certainly transplant has morbidity because of infections, PTLDs, but there is always a risk of donor-derived malignancy as seen in this particular case. And published literature since 1987 has shown 10 cases of donor-derived CNS cancers. There have been 7 GBMs, 1 meningioma, 1 non-Hodgkin lymphoma, and 1 medulloblastoma. So this is our case. as you can see, looks very epithelial. This is large cell undifferentiated carcinoma, which would be in the differential, very similar to our case. And this is a primary CNS GBM, just to show you what we had in this case. So points to remember: donor-derived cancer, extremely rare. Extracranial mets can occur with primary CNS tumor. In this case, the donor already had metastasis outside the cranium into the lungs before they were transplanted into the donor. So clinical history and IHCs are critical. Clinical history is very important. Here comes the question. A week after Mozart died, his ghost was discovered trying to erase his music. When asked why it said, what was the answer? So Mozart's ghost was erasing his own music. He said, I'm decomposing. So this is the next case, 48-year-old man, incidental 6 centimeter distal esophageal. So I'm all over the body this time. So past history was significant for a hiatal hernia as well as varices found on endoscopy in the esophagus 3 years before this. Now you're looking at an EUS guided FNA of the esophagus. So 48-year-old man, and this is an esophageal mass, 6 centimeter. You can look at the amount of cells, the type of cells, the architecture. Lower magnification gives you a beautiful illustration of the architecture, whether it's nested, papillary, trabecular, glandular. It's a beautiful case. You will never forget. And the importance of doing these unknown cases, Dr. Rozaya always used to say, you read it in the textbooks, you will forget. But when you are quizzed in an unknown case session, you will never forget. So you'll always remember someone in Lahore at an IEC tutorial showed us a metastatic GBM, which was donor acquired. You will never forget. So this case you will never forget. More or enough? You can see the architecture, papillary, nested, or something else. Enough or more? Higher magnification? Nested or papillary? Papillary. More or enough? More? So what's going on? Staining artifact. Every nucleus has an inclusion. That can't happen. But papillary with intranuclear inclusions. You can ask me a question about the history. It's so easy. So what's the question? I'm happy to answer. So you mean neck or thyroid? Thyroid. Is there, you want me to answer if there is history of a papillary thyroid carcinoma? No. 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 HSV is a beautiful thought, but how come every nucleus has an HSV change? That is an important thing. And again, if people were not impressed, look at that. History of brachial plexus, brachial cleft cyst, but this is esophagus, so there's, but no history. Adequate? Abnormal? Neoplastic? But you thought HSV, so again, could be right or wrong. Malignant? Yeah, it'll be very hard to go malignant when you don't even want to say neoplastic, right? And I would not dare even ask you the type of malignant tumor. So papillary with intranuclear inclusions, papillary thyroid carcinoma, but unfortunately, we don't have the history. So papillary tumors are thyroid, lung, bladder. Nested tumors are bladder, meningioma, melanoma. No one thought of meningioma. Perivascular epithelioid cell tumor or picoma. Micropapillary could be breast, bladder, lung, adeno, or melanoma, just to help you. So again, this case I used in an ASC seminar, and I asked 4 people, 3 past president and 1 very senior technologist who was also president of her own society for the answer, and here are the answers. One most experienced pathologist called it picoma. Another expert pathologist called it papillary carcinoma from the thyroid. Another panelist called it favor low-grade papillary adenocarcinoma or some weird benign process. And one panelist called it simply papillary thyroid carcinoma. So these are the 4 most experienced pathologists in the world. So we also asked the panelists to vote. Close to half of them thought what you were saying, herpes infection. So maybe it is herpes. 22%, 1/4 call it adenocarcinoma of the esophagus or simply NOS. 16% call it metastatic papillary thyroid carcinoma. 19% call them hepatocellular carcinoma, squamous cell carcinoma, squamous papilloma, ectopic pancreas, paraganglioma, epithelioid cyst, or I don't know. And there was simply other miscellaneous diagnoses. So just to give you differential, that is herpes. So some resemblance to our case, as you can see here, but why every single nucleus look like herpetic nucleus? That would be unusual. Herpes in a pap test, again, amazing resemblance to our case, inclusion like, but our case was nested papillary and herpes infection of which cell? It's forming a mass. So it's not like it's infecting an esophageal lining. So it's clearly a mass. Maybe it's an ectopic pancreas infected by herpes. So it's just called solving the maze. Either these are normal submucosal glands with some staining artifact. This is benign viral change or some kind of hamartoma. Maybe it's a well-differentiated adenocarcinoma and Barrett's esophagus. This is our case with the same inclusions. Maybe it's an epithelioid mesenchymal tumor. Maybe a malignant melanoma. Maybe a papillary thyroid carcinoma. And we don't have the history of that. Maybe it's an occult papillary thyroid carcinoma. But location is odd. Why to have isolated metastasis in the esophagus? And morphology to some extent is also odd. Again, we never see so many internuclear inclusions, even in a papillary thyroid carcinoma. So essentially, what we have is a papillary or nested lesion which looks epithelioid, and it has numerous, abundant intranuclear inclusions. Absolutely. Blame the patient now. I'm sorry? So which stains would you like to do? Negative. 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 Oh, which one? EMA. EMA would have been negative. Meningioma is a beautiful thought, absolutely. They can have internuclear inclusion, but not that many. P63 would have been negative. Cytokeratin may or may not have been positive, maybe focal, but probably not. PAS was not done, but would have been negative. GATA3 would have been negative. So luckily, I have an observer working with me when I signed this case out. He was from Turkey. And he was always on his cell phone while signing out. And I sometimes used to get sick of his habit. So he was on the cell phone. We were looking at this case. I said, can you check what in esophagus can have intranuclear inclusions? And he said, no problem, tuck, tuck, tuck. And he had the answer. Could this be an epithelioid cyst? And he found out an article which said intranuclear inclusions are present in 100% of epithelioid cysts. So even with that information, I was very hesitant to call it epithelial cyst. So I wrote a long note after calling it consistent with an epithelial neoplasm. Out of embarrassment, I would not show you the note. But at the end, I said the possibility of an epithelial cyst should be considered. And patient underwent a distal gastroesophagectomy with lymph nodal dissection. And there was indeed a tumor, firm tan brown, which measured 6 centimeters. And there were lymph nodes also, periesophageal. Largest one measured 2.7 centimeter. That's the squamous lining. And underneath, you see the same tumor, exact same morphology, nested tumor. And at higher magnification, as you can see, every nucleus has an inclusions. So indeed, there was a lymph nodal involvement also, but most gorgeous intranuclear inclusions you can ever see in any case. And that's the lymph node, which had positive metastasis. And based on morphology and immunohistochemistry, it was signed out as malignant gastrointestinal stromal tumor with 4 positive nodes. So what a case this was, as you can see. So it's 6 o'clock, so we'll stop. As you know that most of the time the gist is spindly, and I often call it cigar shape or Cuban cigars, which you see often. The epithelial gist, as shown on the left-hand side, is the rare one, which can have best intranuclear inclusions that you can see. So at the end, I have one last slide to show you. The worst mistake is not to make any. And today I showed you my own mistakes of people who work with me. And the main reason was to educate each other. So I'm sure that along with all the jokes or the entertainment, we all learn from these cases. This was my last presentation, although I will be around tomorrow, at least half of the day. But I just wanted to conclude by saying what a pleasure, memorable trip this is to be back in Pakistan amongst friends. And hopefully we'll do it again. Thank you.